تمام. Okay, Assalamualaikum warahmatullahi wabarakatuh. Everybody's here?
Waalaikumsalam warahmatullahi wabarakatuh.
Semua orang ada?
Ada
35 kan?
38.
38 means that 3 more missing.
Yes.
3 more.
Nampak 35. So we need 4 more. Okay, I'm just going to wait for another couple of minutes. By 10:15 to start. It looks like you guys coming back on the 3rd of August to the campus.
Yes, Doctor.
Yes, Doctor. 3 August. 3 August.
3rd of August Okay, so I think I'm going to start soon. Let's start with Kitab Al-Fatiha. Okay, so I've been asked to basically present in terms of physical examination for neurology for a starter for you guys. I presume you guys have already done internal medicine already, and you guys have done internal medicines. Can you all hear me well?
Yes, doctor. Can hear.
Yeah.
Okay, fine.
Yes, doctor.
So you're just going to go through in terms of the way how to do physical examination for neurology. The thing is, this is not the best way how to teach you guys how to do neurological examination. Okay, because I don't really have a passion with me, and I'm just doing this in terms of giving lectures through the PowerPoint slides. After Raya Haji nanti, so you guys need to ask your mentor to do the neural examinations, bedside nuclear examination. So hopefully this can be done. Obviously I'm doing this teaching at home. At the moment, I think in medical center there is one patient that there is ada neuroscience lah, but that patient is only about 10 months old babies, so it's still okay for you to do a neurological science on these small babies anyway. Okay, so I'm just going to show you my slide examination. Right, can you guys all see my slide?
Yes, doctor, can see.
Okay, good. All right, fine. So physical examination for neurology is same as you doing examination in adult anyway. It's the same. You're doing the same kind of like tone, power, reflexes, coordination, and so on. It's just that the way that you approach the child is slightly different compared to when you're doing it's just that you are dealing with a small child, not adults. Okay, so it's slightly different in terms of the way how you approach it, but examination point of view is the same thing. Okay, so the objective of this session is about for you guys to be able to do neurological examination in babies, in infants, and also in children. Okay, and then you probably want to know in terms of how you're going to rationalize what test you want to do if you find any neurological signs or neurological sequelae. Okay, and if there is any dysmorphism or dysmorphic features, you need to know what to say, what you are dealing with, and what you find, and also what is the signs that you got. So if you got hyperreflexia, hypertonia with weaknesses, most likely it's an upper motor neuron lesions. And the opposite of that is a lower motor neuron lesion, which is hypotonia, hyperreflexia, and obviously with the weaknesses. Okay, so and obviously, before you do the physical examinations, you want to know a bit of more history from about the child itself. Okay, so in other words, if the child can say to you what was the problem, they can always ask the child. If the child cannot tell you the problems or the symptoms or pre-verbals, then you depend on the parents to say. What is the symptoms or ataupun what is the presenting complaint ataupun history of presenting illness. And so obviously history is very important because 70% of the cases you can diagnose from the histories. For example, if I give you a 7-month-old child who coming with right-sided weaknesses, mana dia ada macam stroke-like weakness, maybe last week the parent says that the child has not been moving their right hands or the right limbs. So always been using the left hands to pick things up. So if you got a 7 months old, you expect a 7 months old start to be reaching for toys, mouthing as well. So if you see a child that not mouth, so basically just using just one hand, picking up one hand, mouthing one hand, and the right hand is just not moving at all. So there is a definite weaknesses of the right side. And okay, so this is a red flags ataupun alarming lah. So it could be because of the cerebral palsy, or it could be some sort of infantile stroke and so on. Okay. So the history is very important. If a parent says that the child have right-sided weaknesses last week, then the right-sided weaknesses getting better over time, over 3 to 4 days, and then this week the child have left-sided weaknesses as well. It means that the left side not moving at all, but the right side's being functioning as normal. So you've been thinking of why this kind of why this child has been having, we call it shifting or alternating kind of hemiplegia. Kan? Faham? Have you heard this story before? Alternating hemiplegia? Mana one-sided at one point mana dalam satu masa dia ada satu side yang weakness, and then this side getting better, and then after a while they got another side that weaken as well, and they got better after a few days. So if you not heard about this symptom before and his story before, even in internet medicine, have you heard about this story?
No, tak pernah dengar.
No, doctor.
So I'm not making up a case. Definitely it's not sucker. It's not kena rasuk jin. It's not about because it's a 7 months old baby. So 7 months old is not going to do making things up. So this is a true story. It's a true case. Okay, so this is the kind of history that you kind of puzzling what could be. So I'm telling you the example of things that come across in neurology. Yeah? So we call it alternating hemiplegia, which could be a genetic condition anyway, but it's a very rare occasion. But what I'm telling you guys is the most important things in neuro cases is history. So you need to make sure that there is a proper history being taken, a very detailed histories. So, but the thing is, you want to know where exactly this child has been developmental milestone dia macam mana. So, in neuro cases, you want to know about the motor complaint. So you want to know whether the child has been achieving their developmental milestone. So you expect by 6 weeks old, the child should be the child should have kind of like left to right movement of the neck. Okay, you want to know about the head lag. You want to know about whether the child can hold their head when they are sitting up. So you want to know whether the child has been able to sit up with the curved back at the age of 6 months, with the straight back at the age of 9 months. You want to know when the child standing up, pulling their bodies up, standing, walking, and so on. So you also want to know, is there any abdominal movement in terms of whether it's a seizure, it's a tremors, and so on. So those are the things that you want to know in terms of history point of view. If the child is much more older, like probably 5, 6, 7 years old, they probably can tell you about the sensory complaint. So they might have a bit of kita panggil numbness. Kalau orang Malaysia dia panggil semut-semut kan. Orang Kelantan cakap kebas, bukan kebas, serbet. Orang Kelantan cakap serbet. Tangan ke kaki and so on. So if they can verbalize, they can tell you whether they got any sensation loss, tingling sensation, numbness, painful on touching and so on. So those are the thing that if the child can tell you the presenting complaint. Okay, obviously. When you see a child with a neurological condition, you also want to know whether there is any loss of consciousness. Okay, Loss of consciousness is very important, especially if you're talking about seizures. So seizure, you need to know about the pre-ictal, post-ictal, pre-ictal, ictal, and post-ictal. So pre-ictal, you want to know any history of aura. Ictal is more towards semiology of the seizure, whether it's an absent seizures, whether it's a tonic-clonic seizures, whether it's myoclonic seizures, whether it's a spasm seizures, and so on. So it's very important to know what was the motor function and also the consciousness levels. In terms of developmental milestone as well, you want to know about the speech as well. So is there any speech delay? So if the child's not been speaking by 2 years, 3 years, and so on, and means that the child might have speech delay early on. And obviously, parents need to know in terms of their developmental milestone. So you need to ask the right question to ask the parents. Is there any other history in terms of autonomic symptoms like vomiting, palpitation, and syncope? Syncope is like if changing of the position. So if you are squatting or sitting down and then you suddenly standing up and then you had a syncope ataupun fainted episode. So those are the autonomic symptoms as well. And sometimes you can faint if you hear loud music or loud noise. And sometimes you can faint as well if you've been triggered with things that you don't like pain, like being surprised by things. And then visceral complaints like incontinence, retention, distension of the abdomen, and so on. Okay. So it's very important as well. You want to know in terms of you need to make sure that there is that you know the chronological orders of the histories, the onset of the illness, how long, whether it's a cyclical, when I say cyclical means that there is a pattern. So the child getting unwell every 3 months, mesti unwell and then get better, and the first 3 months he's been okay, and then after 3 months he get the same thing as well. So those are in terms of the cause of the illness. Okay, so you want to, or the child only get seizure when they are unwell in terms of with the fever. So you're talking about fever hypovalescence. Okay, so you want to know is there any other factors that can associate with the illness? So if you're talking about seizures mainly, so does the seizures tend to be brought up by possibly being unwell or not sleeping well, not eating well, and so on. So those are the things that you need to think about. You also want to know more of their past medical history as well. So was the child was premature when they were born, like preterm babies, 26 weeks, 28 weeks. Does the child needs phototherapy? How long? Is it severe jaundice? Is it the jaundice needing external transfusions? Because jaundice also can cause kernictures, which can sometimes cause cerebral problem as well. You also want to know is there any family history of seizures, if there's any family of seizures. You also want to know is there any past medical history of meningitis or admission to PIC and so on. So those are the things that you really want to get the detailed history when you see a child with the neurological conditions. And then is there any investigation done? Any treatment has been given. So if there is any investigation, you want to know the result of the investigation. If you have somebody who might have kita panggil metabolic condition ataupun mitochondrial conditions. So sometimes the mitochondrial condition, if you do it too early, then the MRI brain might be normal. If you do it after a couple of years, then you might see changes because of the progressiveness of the illness. So you want to know when was the last investigation done in terms of scanning. Okay, then if it's been done 2-3 years ago, you probably want to repeat the imaging again, because you might see changes in the brain. And if any treatment been given, you want to know how long the treatment been given. Was the treatments working. So you want to know the response to the treatment as well. Because if you got a child with seizures, and the seizures is very, very difficult to control, so you want to know whether the child has been on epilim, how long the child has been on epilim, does the seizures really control with epilim? Okay? So if the epilim is not being given, so if you not control the seizure, you want to know whether there is any other medication being add on or being reduced or being taken out, being add on to the illness. Okay, so because sometimes you can have a child that is multi-drug resistant epilepsy, which means that they might be on multiple medications. They might need PICU admission due to status epilepticus. They might be on ketogenic diets. They might have epilepsy surgery and so on. So those are the question and the history that you want to take from the parents. Okay, so this is all the thing that I can be covering before as well. Obviously, trauma is very important, and also you want to know if there any history of head injury, regardless whether it's a minor head injury or major head injury or any car accidents, the fall from height and so on, and also a history of being under GA, because sometimes if you have a neurological condition, sometimes you might have a response differently to the GA. So those are the things that you want to know. Okay. And then this is all the thing I mentioned before. So antenatal histories, you want to know the antenatal infections, medication, or maternal problems like epilepsy, diabetes, and so on. So for example, if moms was on epilim during pregnancy or any medication during pregnancy, sometimes if the medication is not being changed, for example, valproate, so sodium valproate. If the sodium valproate is not being changed during pregnancy, sodium valproate is a teratogenic medication. So sometimes the child can have, we call it fetal valproate syndromes. So those are the things that you want to ask further. Okay, and obviously in terms of postnatal, like any fetal distress, any admission in ICU, and so on. Developmental history, as I mentioned before. Okay, so this is kind of like reflexes that you want to do in babies. So the first, okay. Let's just see whether you can see my cursor. My cursor tak keluar. Tak keluar pula cursor. But if I do this, can you see my cursor?
Yes.
Okay. So when you see a baby or when you examine a baby, okay, just want to put it a bit bigger here. When you see a baby, so you do this test. We call it a retraction test. The reason you do a retraction test, you want to see the head lag. So was the child very lagging of their head when you pull them up? Okay, so the pulling test. So what you want to see, you see how lagging is their head, because most of the babies, they might hold their head static when you pull them up. Okay. So and also when you see a baby, you want to see their posture. So what kind of posture they are doing. So if they are awake and active, so the posture normally flexion, or they might have movement. Okay, so that shows their power. Manakala they ada anti-gravity movement, that means that they got good power. Okay, and good movement. Okay, so and most of the time babies are they are in the flexion position, which is a normal position for them. Okay, if they are floppy, weak and floppy, so they might have weaknesses. Okay, if they're sleeping, that's fine. But if they are relaxed and also macam macam hypotonic tapi sleeping, that's probably normal. But most of the newborn baby in the first couple of weeks, like 3 to 4 weeks, when they're sleeping all the week, they're quite flex in terms of their upper and lower limbs, which is quite normal. Okay, you also want to know sort of sucking reflex. So when you put in your fingers or anything in the mouth of the babies, they will start to suck. This is just to demonstrate the palmar grasp and also atonic reflexes. So if you turn the baby's head to one side, they are doing kind of like in a fencing position. So one so if you put them on the right side, the one hand will be extending and the other hand will be kind of flexing. So dia macam orang tengah main fencing kan. So these are the tonic neck reflex.
Doktor,
Okay.
Doktor, can I ask? Doktor cakap pasal sucking reflex kan, saya belajar yang dia ada sucking reflex dengan rooting reflex. Is there any difference or is it the same?
So the rooting reflex is if you gently touching their cheek, they start looking for things to suck. Okay, kalau macam korang let's say like this, if you touch their cheek, they will start rooting to find the fingers to suck. So those are the rooting reflex. Sucking, you put your fingers in the mouth, they will start sucking the fingers straight away. So they don't root for the fingers because the fingers already in the mouth, so they start sucking. Rooting is the mouth movement to find things to suck. So normally if you gently touch their cheek, they will start the mouth start moving and looking things to suck. So that's what normally if you breastfeeding a baby, so normally the mom use the nipple try to stimulate the rooting reflexes. So gently rubbing the nipples to the cheek, and then they just start to look for the nipple. Okay, fine.
Faham.
So those are the difference between sucking and rooting. Okay, and then this images is showing we call it a ventral suspensions. Vertical suspension. So if you making the child in a vertical position, so the child is maintaining their tone, so they're not slipping through your graph. So one of the things that you want to when you do the vertical suspension is you want to know whether the child is slipping through your grasp or not. So dia macam dia punya tone dia macam jatuh when they do it. So this is just to assess their tone and also power and muscle as well. And sometimes you can do the stepping reflex as well. So when you put them on the vertical suspension, you can see the child is basically trying to walk. So we call it stepping reflexes. And then obviously the motor reflex and so on. But I think that's okay for the time being. Okay. Nutrition and also vaccination history is very important as well, especially the polio. Okay, so make sure that you ask history of polio if you see a child coming with hemiplegia ataupun lower limb weaknesses. Family history. So family history is very important in terms of consanguinity. So marriage between cousins. Because it is any cases of like mitochondrial cases ataupun rare genetic condition can raise due to the consanguinity marriage. Okay, sometimes migraine also can run in the family, and also hereditary like neurodegenerative ataupun autoimmune neuro condition also can run in the families. You also want to know in terms of family history, yang dia ada multiple abortion, multiple spontaneous miscarriage. So meaning that the parents has been married for like 15-20 years. Mak dia selalu je miscarriage in that time. So sometimes you worry about possible genetic conditions or possible of kidney problem and. So basically something not right with the child. Metabolic condition also can cause stillbirth as well. Okay, so when you examine a child, you basically want to see any signs to suggest upper motor neuron or lower motor neuron lesions. And obviously, congenitals mainly happen from birth, but sometimes you don't realize that the sign and symptom at birth. So you might realize the sign and symptom probably after 6 months of life. Metabolic condition also same as well. So sometimes it can happen at birth, sometimes it's happen 6 months down the line. Genetics like in Down syndrome, Pathological syndrome, Edwards syndrome, and a few other syndromes that can cause neurological conditions. Infection, inflammation, and also immune causes. Vascular, so you can have childhood stroke due to possible hemorrhage or possible thrombosis. So it's not just adult have stroke, children also can have stroke as well. But obviously the pathology in adult is slightly different. It's different compared to children. Trauma, so traumatic head injury. So if you got accidents or fall from a height, then you can have a traumatic brain injury, and that also can cause CPs and so on. Obviously, malignancy also can cause a problem as well. Okay, so how are you going to approach your child? So this is where you start your examination. So when you start your examination, so what you want to do is you want to introduce yourself that you are so and so, that you are going to examine their neurological system. But obviously in Malay you say, saya Dr Azamin, saya nak check anak puan punya nak check sistem saraf anak puan. So itulah, so you can say that to the parents, okay? Or if we ask you to do a specific examination, like lower limb examinations or upper limb examinations, so what you're going to do is you say to parents, so saya nak check kaki, nak check kekuatan, nak check reflex, nak check dia punya koordinasi tangan dia ataupun koordinasi kaki dia. So that's probably enough for introductory to yourself, and also your getting consent from the parents or from the child. So before you start touching the child, you want to make sure that you observe the surrounding of the child. So kalau nampak dia ada wheelchair, then you need to see what kind of wheelchair they have. Is it a man-powered wheelchair ataupun motor-powered wheelchair? So kalau motor-powered, normally dia ada macam joystick kan, yang boleh control dia punya movement. Itu kalau yang automatic electric chair lah. Kalau yang biasa kita tengok man-powered tu just yang ada tolak kat belakang dia. And you also want to know what kind of wheelchair they have. Is it the posture support, or is it do they have any neck support? So you want to know what kind of wheelchair they have. Kalau dia ada mobility aid macam walking frame ke, walking stick, so you need to mention that if they have any mobility aids. Okay, in CP because they got contractures, so sometimes you can see a spleen, and they are wearing a spleen or special boots that they are wearing. So because in CP they have a contraction in the joints, so they need to wear spleens. Some children might have chronic lung disease, ataupun low lung volume. So sometimes they need to be on oxygen tank ataupun oxygen therapy. And some children yang ada CP ni, they have a lot of secretions, and they might be susceptible for especially pneumonia. So sometimes you can see parents carrying suction with them and doing a lot of suction. And obviously if they are on any rice tubes ke, ada drip ke, on a medication, kalau ada, then you just say you make sure that you see these things around the child. Okay, so view from the distance is basically you just see the posture of the child. Is it flex? Is it extended? Was the child dia punya kaki macam mana? Is it straight, or is it scissoring posture, or is it frog like posture? Okay, so it's very important. If the child can stand up or sit up, you want to know whether the child sitting up well or if kalau dia sitting up like this, so it's okay. If the child come like sitting up but kind of like drop into the side, then you want to know that could be an indication that the child have a poor truncal tone, which probably reflects that there might be cerebellar signs there. Okay. Or if the child basically not have any wheelchair, the child probably bedbound. So in that particular case, normally due to no resources to give to parents to buy wheelchair. So most of the time, parents will just carry them anywhere they want, anywhere they want to go. Okay, so inspection of the child. So you need to see from the top to toe, making sure that you inspect the face, any sign of like flatness of bridge ke, hypertelorism ke, long philtrum, low set ears, funny mouth like like a fish-like mouth ke, myopathic face. Myopathic face ni macam they got myopathy, they got a weakness of their facial muscles. So sometimes they look like myopathic. Myopathic means an expressionless face. For example, sometimes you see in the congenital spinal myopathy. So these are conditions that come with myopathic face. Kalau in adult, you can see the myopathic face ataupun expressionless face in Parkinson's syndrome. So the face is just dropping down, right? So those are the kind of faces they are doing ataupun itulah mana, because they got very poor muscle power, so they can't really close their mouth because the facial face is so weak. Okay. You want to know whether the child is hit size normal or tak. Is it microcephaly? Is it macrocephaly? And also you want to know the shape of the head. Is it plagiocephaly ataupun flat or occiput and so on. Kalau flat or occiput ni maknanya they've been lying on the bed for a long time since born ataupun since they are small. So like preterm babies tend to have macam elongated face. Mana dia punya tepi ni macam kemek sikit, dia punya frontal and also occipital is quite elongated. So those are typical head shape for preterm babies. Okay, but obviously you need to make sure that you measure the head circumference. In terms of brachycephaly, like Down syndromes, and sometimes craniosynostosis, a child with the Crouzon syndromes, like you can see that the eyeballs is popping out due to the misfusion of the skull sutures. Okay, you need to inspect the neck, okay, because sometimes they might have tracheostomy. Okay, and also some child who has hydrocephalus ataupun post-hemorrhagic hydrocephalus, so they might have the shunt. So you want to make sure that you inspect the behind the ears to look for the shunts. So the preterm babies might have hydrocephalus ataupun baby yang ada hydrocephalus, you can see the shunt. So when you can feel the shunt behind the ears, then you run your hands down to the neck and down to where actually the shunt terminated. So because most of the time you have VP shunt and ventriculoperitoneal shunts. So you want to make sure that you feel the shunts down to where it is end. There is few type of shunt. You have ventriculoperitoneal shunts, you have ventriculoarterial shunts, you also have ventricular pleural shunts, and you have lumboperitoneal shunts. So there's about four type of shunts that you can see. But most of the time, I would say almost 90% of the time, you will see the VP shunt, which is ventriculoperitoneal shunts. Okay, and then also you can have webbing of the shoulders, probably indicating the Noonan syndrome or Turner syndromes. Torticollis. So torticollis is like a child that cannot move their neck; they just staying at one side because of the muscles tense in the neck. And obviously sometimes some children might have a scars like a central line scar. So look for those signs. Okay, eyes, as I mentioned before, so screens, glasses, cataracts, that's the child fixing and following. So fixing and following should happen from the age of 6 weeks. So by 6 weeks old, if you see a baby that's not fixing, means that if you put a red object in front of their face, and if you move the red object around, the child should start to follow the object, fixing and following. If they've not been doing that, by 6 weeks or by 8 weeks, then the child, you need to assess the vision of the child. So there might be a reason why the child is not fixing and following by the age of 6 to 8 weeks. So that's why in babies you expect them to start smiling socially by the age of 6 weeks, or by the age of 8 weeks. Okay, if they're not smiling by the age of 8 weeks, then you worry that they might have problem with their eyes. Okay, so hearing aid, if there's any hearing aid, mouth, nose, so any tube, any gum hypertrophy, any dental caries. What about the tongue? Is there any fasciculation of the tongue? Was there any drooling of the saliva? And what kind of speech they are saying? Is it slurred speech, or is it missense kind of speech, or dyspraxia? Because sometimes speech can be early sign to say that this could be autism or no autism. Okay, so I'm just going to show in terms of the way that you examine a child. Obviously, it's so difficult because you can't really do it, online. Actually, I want to go through. So what we're going to do today is just going to go for cranial examination and also peripheral motor neurological examinations. So let's go for cranial examination. So you got about 12 cranial. So the first one is olfactory, which is not, you don't only do the olfactory until the child is quite big child, like 5 to 7 years old, who can verbalize their thoughts. So if you got coffee, so I don't know whether 7 years old child tend to drink coffee or not. So I don't know whether 7 years old child know what is the smell of coffee. Okay, so if I ask you guys, what age do you drink coffee? 3 years, 4 years? You don't remember when you start drinking coffee, and so sometimes what you have to test for your olfactory nerve for the smell, you need to know what the child has been exposed to that particular smell. So I think the best one is orange, yang paling common. So if you can have two smells, orange ke ataupun I don't know lah, musang king kan, saling tak tahu lah budak-budak umur berapa makan durian kan. So something that's more common in yang you guys can test to test for the olfactory punya nerve. The second nerve is optic nerve. So you test it for the visual acuity. So if a child needs to wear glasses, ask the child to wear glasses, and then because you need to test each of the eyes. So if they are wearing glasses, then ask them to wear glasses, and then after that, you just ask the child to close one of the eyes to read for ABCs ataupun 1 to 3 and so on. So those are visual acuities, and then you want to go for visual field. Visual field is like you need to sit with the child in the same plane. So your eyes and their eyes is on the same plane, close on the eyes, and then you basically doing the visual acuities to look for the 6 areas. Okay. Accommodation is just basically making sure that the eyes can converge. So you just ask about accommodation of the eyes, and also you're doing the light reflex, direct and also consensual light reflex, which is quite common, which is quite easy to do. And then you do the 3, 4, 6, which is oculomotor, trachea, and also abducens. This is the main thing, just looking for the eye movement. So you do the H movement. Okay, so you want to make sure that the child does not move their head, just the eyes follow the fingers. Okay, And then you want to, when you do that, you want to see is there any nystagmus or is there any weaknesses of the eye movement. And at the same time, you want to ask the child, tell you when the child sees the double visions, okay? Because there could be some sort of palsy of the cranial nerve number 3, 4, and 6. Number 5 is the trigeminal nerve. It's basically a sensation. So you feel the sensation of the maxillary and also mandible region. So you want so sensation. So you want to know whether they can feel the soft touch and also sharp touch when you do the trigeminal nerve. And also you want to know whether they got good muscles of the face. So you ask them to clench their teeth. So at the same time, you want to feel the masseter muscles when they clench their teeth. And also you ask them to open their mouth when you try to push their chin, or try to open their mouth so that you can push their chin. So those are way that you try to assess their muscles of the jaw. Vestibular cochlea is basically testing their hearing. So you can test their hearing using the tuning forks for the Renus and Webers. Okay, if you don't have the tuning forks, you just whisper to their back and then making a noise to the other sides. Glossopharyngeal, which is number 9, you ask them to open their mouth and say ah, and you want to see the uvula, where is it going. So if the uvula stays straight, which is normal. If you divided to one side, means that the lesion is on the is where the uvula deviated to. And you also want to assess their cough. So if they are coughing well, means that they got good cough. If they can't cough properly, we call it bovine cough, like so cough, it should have good cough, like so those are good cough. But if they got any problem with their glossopharyngeal, they have very, very weak cough, like macam bovine. Bovine is macam lembu. So those are kind of like bovine cough. In that particular case, you worry whether the child might might have problem with their swallowing and so on, because sometimes child that have glossopharyngeal nerve palsy, they can't really swallow very well. Vagus nerve is a nerve that controls your voice. So sometimes you ask about the hoarseness of the voice, if there's any hoarseness of voice. Accessory muscles, number 11 is shrugging their shoulders, and you kind of pushing them down, and also turns toward right and left. So basically, you ask them to go against your hands for the accessory muscle, sorry, accessory nerve. And then hypoglossal is sticking out the tongue. If they deviate to one side, means that they got palsy ataupun lesion to that side. Okay, so before everything, before you do everything, you also want to check their mental status ataupun your GCS level. So if they are opening their eyes and moving spontaneously, and actually talking to you spontaneously, means that their GCS is 15/15. Make sure they have good behaviors, means that they're behaving appropriately. Because sometimes if they got encephalopathy or confusions or encephalitis, then they might not behave appropriately, and they might swearing at you as well. And obviously the dysmorphic features. The handedness means that are they left or right-handed? Okay, because the left and right-handed, probably you can see where was the lesions. For example, if you are right-handed, so most of humans, about 90% of us, our speech center will be on the left side. Okay, so that's quite common. So if your child have any problem or any lesion around that speech center, okay, so the child might have speech delay or might have slurred speech. Okay, if the lesions is around your cortex areas, then you might have problem with your movement, with your gross motor, with your fine motor. If the lesions happen at the back of your brain on an occipital lobe, then it will be affecting your eye, your visions. If the lesions is around your frontal area, that will be affecting your high cognition function, high cara berfikir, IQ, and sometimes it also can affect your behavior as well. So these symptoms ataupun signs, actually you can have like knowing where exactly the lesion are. So okay, so if the child coming with the visual problems, then the lesion could be in the occipital areas. If the child coming with the lesion with the symptom affecting their muscles, their power, their coordination, or their motor skills, then it could be the cortex, the central, the temporal lobe areas. If they're affecting if lesion affecting the temporal lobes, then it could be the hearing. So with the symptoms and the signs, you can start knowing where exactly the lesion are. If you do the peripheral motor system, okay, so you basically inspect the muscles, the posture, the muscles, bark. Was there any wasting? Is there any scars? Is there any fasciculation, and so on? Okay. So when you're doing when you're doing the peripheral nervous system, then you basically need to do tone, power, reflexes, and coordination. So let me go back to my other slide. Okay, let me. Okay, let me go back. Okay, so this is just a slide for checking the peripheral nervous system. Okay, so we're mainly talking about tone, power, reflexes, and also coordination. Okay, so the first thing you want to do, inspect the limbs. So if you've been asked to inspect the lower limbs, then you inspect the lower limbs. Means that when you expose the child, you want to expose the child from the belly button and also downwards. Okay. When I say belly buttons, because the reason that we want to expose the belly button is because that you want to see all the muscles, all the limbs from the hips down to the toes, and obviously you want to cover them. So if they got boxes at the shot, obviously ask them to keep. You need to protect their dignity. But the thing is, you want to make sure that you're looking at the hypertrophies. Is there any hypertrophies to one side compared to the other side? Is it hypertrophy or is it wasting of muscles? Is there any movement activities of the lower limb? For example, any tremors, any fasciculations, and also obviously movement. Atetosis is movement. Dystonia is also movement as well. Tremors and cora is movement. Okay, and obviously is there any abnormal posture, any scars, and injections, scars, and so on. Okay, and then you do the tone. So when you do the tone, you basically if you do upper limb tones, you basically check the shoulder tone, the elbow tone, the wrist, the fingers as well. And same as when you do the power, you ask them to do the like a chicken wing, okay? Do the wing and see whether they can resist your force. Same as when you do the elbow, and make sure that you compare 1 to 1. If you do right elbows, then you need to do the left elbow. If you do right wrist, then you do the left wrist. Bukan buat satu limb, habiskan satu limb, and then baru buat second limb. Tak. You need to compare at the same time. Okay. So shoulders like that, elbow this and this, wrist up and down, fingers, spread your fingers, and then see whether they can spread their fingers. And then you can ask about putting the peppers in between the fingers and see whether they can hold peppers by doing that. For the lower limb, same as well. You do the knees. Susah sikit nak buat. Tak tunjuk sikit. So knees, kalau hips tu, make sure you do the hip flexion, hips extension, adduction, and also abduction. Knees, extension and flexions. Foot is basically inversion, flexion, dorsiflexion, extension, eversion, and obviously you also want to assess the gait as well when you do the lower limb examinations. Okay, and when you do the gaits, you also want to do the heel to toe, heel walking, toe walking, and straight line walking. Okay, sorry. Okay, so those are the tone and power. For the upper limb, you do the reflexes. So reflexes there, you do the bicep reflexes, you do the tricep, bicep, and also the brachioradialis. Okay, the finger flexion. Nowadays we don't really do much of the finger flexions. Okay, so those are the upper limb. The lower limb reflexes, you do the knee jerks, you do the ankle jerks, and also you do the Babinski signs. The cross adduction is not easy to do in children, but at the same time you can do the posterior tibialis, which I need to show it to you, but I don't think that it is important in neurological examination. So the most important one is the knee jerks, ankle jerks, and also Babinski signs when you do the lower limb reflexes. You can ask your mentor to show you what is posterior tibialis reflexes, which is not normally, not many people do the posterior tibialis. Okay, and this is just kita panggil classification of power. So no movement, not even a muscle move, then you call it 0. If there are any flickers of the muscle movement, we call it 1. If there is a movement, horizontal movement, there is 2. If there is any anti-gravity movement, we call it 3. Anti-gravity movement with some resistance, we call it 4. And then full power is 5. Okay, tone, we just say tone, normal tone, spastic tone, rigid tone, hypotone, and so on. The tendon reflex, if there is absence, you call it 0. If there is some tendon, so sometimes trace and normal is so difficult to say. But so that's why it's very important to compare the two sides, because you cannot compare your the patient's reflex compared to your reflex. The thing that you can compare is you can compare the right and left of the patient, not the patient with other patient. Okay, because they are different. Okay, and obviously when it's clonus, you can say it's clonus, but clonus is divided by 2, non-sustained and so the sustained clonus. Non-sustained means that when you do the clonus, especially the plantar clonus, when you do clonus, so if it's sustained, it will continue flickering, or it will continue they can clonus all the time. So those are the sustained clonus. Kalau yang non-sustained mean that they might have clonus for a while, after a few seconds, it stops. So those are non-sustained clonus. And sometimes non-sustained clonus is quite normal. Okay. And then the next thing that sometimes we don't really ask you to do is the sensory test. We don't really do much of sensory nowadays, but if you've been asked to do a sensory assessment, then you need to know the dermatome, which is this slide. Okay, very important to know the dermatome. So this is the dermatome of the upper limb. This is the dermatome of the lower limbs. So you need to know the dermatome. So we don't really do in terms of if you want to do dermatome, if you've been asked to do dermatome, then you need to have at least 2 sensations. So soft touch and also the sharp touch. The sharp touch is normally kita tak buat sangat because it will induce fear from the patient, and sometimes you worry that you might have caused injury to the patient. So that's why most of the time we don't really do sensory cuma kita boleh buat soft touch lah. So when you do the soft touch sensation, so you just follow the dermatom of if you ask to do upper limb, then make sure that you know the dermatom where to touch and so on. So cuma dermatom we don't really do much in terms of unnecessary, kita tak buat sangat in children, especially in children of less than 5 years old, because they don't really know. It's difficult to comply and difficult for them to understand the instruction. So those are the sensory. Okay, and the last one is the cerebellar signs. The cerebellar signs, I'm not so sure whether internal medicine teach you guys cerebellar signs. Ada ke? Do you guys expected to do cerebellar sign?
Ada.
Ada.
Ada, doktor.
So cerebellar signs in pediatrics is the gait and also the coordination. Okay, so normally, so part of your lower limb examination, upper limb examination, you do the tone, power, reflexes, and last one is coordination. Coordination of the upper limbs, you asked to do you ask them to do the nose to yang movement, nose and touching. Those are the coordination of the upper limbs. Or if the child is quite well, and then dia dah besar sikit, dia faham instruction, then you can ask to do the clapping punya movement. Okay, so sometimes patient yang ada masalah coordination, they can't really do the apa namanya? Dia macam apa?
Dysdiodokinesia.
Yeah, so if they have this diaconokinesia, they can't really do the alternating rapid movement. So like us. We can do this quite easily. So if they got cerebellar sign, they can't really do much. So sometimes they just do like this. So because they can't really do.
Kedai design kedai rambut kan?
Apa? Ada orang cakap apa ni? Okay, so and if they have cerebellar signs, they might have a quite tremors sometimes, or something they got pass pointing because they can't really coordinate ataupun predict the distance. Okay. The thing is, when you do the cerebellar signs, tak dengar ke? Hello?
Okey, doktor. Doktor cakap je. Dia dah tutup mic.
Tutup mic So, kat mana tadi? Lupa.
Pointing.
Pointing, yes, pointing. So, when you ask them to point, you want to make sure that they got a straight elbows. Okay, so when macam so touch kan, kalau macam dekat sangat, the elbow is not straight. So if the elbow is not straight, sometimes they can use their shoulder to compensate their tremors. So when you do the pointing punya test, you want to make sure that the elbow is always straight. Okay, because when the elbow is straight, then then barulah betul-betul kita test dia punya coordination. Kalau elbow tak straight, you're not really testing. So that's why it's very important. It's very important to you just need to stop sharing. Okay, there you go. Start sharing. Okay. Inilah cabaran buat online teaching. So make sure that your elbow is the patient's elbow is straight when they're doing. So make sure that you put in your target to far so that they always stretch out their elbows. So bukan macam tu je. To straight elbow there. So you want to make sure that the elbow is straight. Okay. So you always want to move the target so that you can see the hand is outstretched when they are touching the target. Okay. So those are for the upper limbs. For the lower limbs, then you do the gait, which is assessing their walking, and then the other thing is you're doing the heel to the knee and also to the ankles, yang alternating punya movement. So those also can be done as well. Okay, the other thing that you can do about cerebellar sign is assessing their balance. So ask them to stand, close their eyes, ask them to stand on one side, one legs, and also close their eyes. So those are the things that also can be done for the cerebellar signs. So there's few more cerebellar signs that you can do, like, but I think that's probably enough for pediatrics. Just upper limb and lower limb, which is just quite easy to do. And when you assess the gaits, you want to see what kind of gait they have. Does they have ataxic gait, which is the broad-based gait? Is it hemiplegia gait? Is it diplegia gait? And anterodia gait, and also Parkinsonism gait. So there's so many gaits that you need to know as well. So in here, I put in the cerebellar ataxia, which is the myopathic gait, which is the Weddling gait, like a Duchenne muscular dystrophy gait. You can have Parkinsonism gaits, like slow to start, and also difficulty to stop when they stopping. Spastic gait is just like a CP gait. It could be stiffening of the lower limbs, and you can see a specific kind of like diplegic spastic or hemiplegic spastic gait. Foot drop is due to peripheral nerve lesion, so sometimes you can have foot drops, and sometimes you can have a condition called hypoplasia of patella. So congenital hypoplasia of the patella means that they got good power, they got good tone, they got normal reflexes. Cuma when they walk like a ataxic gait, but their cerebral function is normal. So sometimes there is a pathology of the bone that looks like they have a cerebellar sign, but they're not cerebellar sign. They're just a congenital hypoplasia of the patella. So when you patella, they're not really well formed yet. So sometimes you see a child that walking like a duck, dia jalan macam itik. Tapi sebenarnya dia punya neurologically normal. Cuma dia jalan macam itik tu sebab dia punya patella dia not mature yet. So that's why dia punya knee punya joint dia macam a bit loose. So that's why they walk like macam itik.
Doktor.
Yes.
Kiranya yang macam patient with patella hypoplasia ni, kita kena rule out dia punya cerebellar, nak cakap cerebellar condition dia intact dengan buat cerebellar sign yang lain lah.
So you need to do other cerebellar test. So you do the gait will be abnormal because of the patella hypoplasia. But you need to test for other tests like heel to the knee and ankles punya test. You also can buatlah tone, power, reflexes, and so on. Okay, and then how you test? You probably do the X-rays. So hypoplasia of the patella, when you do the X-rays, you don't see the patella. But when you examine the child, you can feel the patella. The patella tu ada, cuma kecil je. Okay, but when you do the X-ray basically there is absent patella. Okay, and normally when you do MRI ke CT brain dia normal basically. So in that particular case, there's not much you can do about that. You just wait for the patella to develop. Normally your patella start to calcify fully or properly by the age of 6 to 7 years. So after that, you will see a good improvement of the gait. Okay. Yeah. So if you go in, yeah. So obviously it's not ideal way to teach neurological examination. I don't know lah macam mana orang lain buat, how they conduct respiratory examinations. Kan?
Like je, Doktor.
So semua lecture kan. So what we can tell you is just, you know, show you the slide, but at the end of the day, we need to show you properly when we're doing BSD later on. So hopefully you know, we will get to the point lah yang kita akan bawa korang jumpa dengan patient untuk properly show you how to do examination, sama ada real patient ataupun simulated patient. But this is what we can do now. The main thing is examination of neuroexamination in a child is different to adult. It's just that you need to adopt a bit more in terms of how you're dealing with children. And obviously, dealing with children is like playing with them. So you're not really examine the child. You're just playing with the child while you examine the child. It looks like you are playing, but you basically examine the child. Okay. Another question.
Doktor, saya nak tanya. Like for example, right? If neurological exam in peds, they are very patient age related. Contoh macam kalau primitive reflex tu part of neurological examination.
Yes.
Sampai umur berapa, at what state of age could include primitive reflex, and at what age diorang faham instruction untuk cranial nerve examination.
So primitive reflex, and normally we don't really ask you to do a primitive reflex in a child of 2 years old. Less than 2 years, there might be a primitive reflex still there, still intact. Then we probably ask you. So normally primitive reflex ni kita tanya masa umur 6 bulan, less than 12 years old lah. Less than 12 months old punya patient. Then you might want to do a primitive reflex. Tapi normally primitive reflex yang ada masa 12 months old ni, Babinski je. Babinski still, if they're not walking yet, the Babinski normally still upgoing. Once they start walking, by 9 months ke 11 months ke 12 months ke 13 months, then you can see the downgoing of the plantar when they start walking. Okay, so primitive reflex, normally if the child is less than 6 months, we will normally ask you to do the primitive reflex. But normally 6 months and above, there's not much primitive reflex that's still intact by that time. Even moro pun by 3 to 4 months dah tak ada moro sangat dah. Even routine reflex pun, you know, by 6 months normally dah tak ada sangat dah routine reflex. Because routine reflex is mainly once the child start to can see properly. Normally the routine reflex tend to disappear gradually. Instruction, whether they can follow instruction, it's all depend on how mature is the child. Some 3 years old child can follow instruction very well, but some 5 years old child might not be able to follow instruction very well. So it's all depend on their brain maturity. If the brain mature quite quick, then a 5 years old can comply with a lot of your instructions. But the thing is, as I mentioned before, it's about how you play with them. So sometimes the patient, when you ask the patient to do this, sometimes they don't follow pun. So sometimes you need to adopt ataupun ubah sikit the way that you assess them. For example, in a child of 2 years old, okay, for 2 years old, they probably don't really know what to do this, what to do that. So sometimes you can have something like a pen, bagi dia pen, and sometimes by doing this movement is involving the shoulder and also the elbows, kan? So this movement, you can assess by doing this movement. If you give them something and then they are reaching out for toys, so sometimes you are bertarik tali dengan dia kan. So with this movement, you basically assessing their fingers of holdings, their elbows of flexing, and also their shoulders movement as well. So in a way, you are assessing their power at the time. Betul tak? So even though you're not assessing a proper in terms of abduction, abduction, but at least you know that by that particular movement in terms of tarik tali tu, you kind of knowing the child have a good power lah. Even though you don't really assess them formally. Cuma we not that cruel lah. So if you want to do the neurological examinations, we normally get you a good cases yang mana easy for you guys to examine the child. Normally, for neuro exam ni, we'll get you the CP patient lah. So CP patient is very easy to assess because CP patient you just assess their tone. You probably don't really need, or you probably can't really assess their power because most of them can not comply with the instructions. So basically, you just observe their movement. You do the reflexes, and most of the child yang ada CP ni, they don't really have cognitive function very well. So sometimes you don't do the coordination because you can't really assess coordination in the CP patient yang ada yang very severe lah. Kalau yang mild tu, yang ada cognition, then you can do the whole thing. But it's all depend on what kind of patient that you have. We have a few patient yang ada permanent seventh nerve palsy, and so but she's very bright, and so she's quite young lah, umur 11 years old, so she can follow things instruction very well. So if you got you to see a child and to examine the neurological signs, normally we bring you the child that can comply with your instruction, and also or we will do the CP patient normally. Okay. Any other question? Nah, no question. Okay, so if there's no question, then I think I'm just going to end the session with touch base with someone else. Okay, thank you very much.
Thank you, Doctor.
Thank you for attending the session.
Thank you, Doktor.
Okay, all right, thank you very much. Okay, Assalamualaikum.
Waalaikumsalam.